Good morning. Habari ya asubuhi. Kiswahili yetu kilikuwa kisanifu sana, lakini I hope it's appropriate. Thank you, Dr. Sekera, for the warm introduction. My name is Professor Kenneth Ngure. I'm the Dean School of Public Health in Jomo Kenyatta University in Nairobi, Kenya. I'm also a member of the Governing Council of the International AIDS Society. And here with me is also Josephine Nakukenya from Uganda. You can wave, because she's also a Governing Council member. We are 4 of us representing Africa. So on behalf of IAS, I would really welcome all of you to this IAS Educational Fund workshop, organized in collaboration with Glaser, Pediatric, AIDS Healthcare Initiative, Tanzania Health Summit, and the Tanzania Commission for AIDS, under the theme Science and Community in the HIV Response, the next priorities for Tanzania. This workshop has been organized very rapidly to further the AIDS 2022 conference that took place in July 2022, and we are extremely grateful to all our partners and the collaborators for their flexibility and efforts for these past few intensive weeks in order for us to get together today on this great program. A few words of the International AIDS Society for some of you who may not be familiar with it is that the International AIDS Society convenes and educates and advocates for a world in which HIV no longer presents a threat to public health and individual well-being. After the emergence of HIV and AIDS, concerned scientists created the International AIDS Society to bring together experts from across the world and disciplines to promote a concerted HIV response. Today, IAS and its members unite scientists and policymakers and activists to galvanize the scientific response to build global solidarity and enhance human dignity for all those living with and affected by HIV. The organization of this workshop falls under the mandate of the IAS Educational Fund program. The Educational Fund provides multiple inclusive educational opportunities for key stakeholders in the HIV response to facilitate bridging the gap between evidence-based science and policy action. One of the program activities includes the organization of regional meetings such as this workshop, and to promote science and catalyze collaborative action at country and regional levels to further to AIS and international conferences. The last in-person meeting was held in December 2019 in India. In 2020-2021, during the first part of 2022, IAS pivoted its regional activities through virtual meetings, but also through many webinars. But I'm sure you all agree with me that physical meetings are much better than the virtual webinars and meetings. We hope that many of you were able to join in the last 2.5 years for those meetings that were held. However, we are more than thrilled to be back today in the workshop in Tanzania. We sincerely hope that, like Dr. Sekera mentioned, to help us support and catalyze actions, strengthen your capacity to continue engaging in HIV response through discussions, that you will continue improving strategies, policies, and practices in Tanzania based on the latest scientific evidence. As you know, we cannot work in silos to end HIV. The IAS places great emphasis in activities that put people first, build bridges, and collaborate, that are evidence-based and open-minded. In our regional meetings, as in all other activities, we want to make sure that voices of health and social workers, researchers, policymakers, and most importantly, people living with HIV, key and vulnerable populations are listened to and heard. It is our role in amplifying these voices in multiple fora where we all have the power to play. We are still accountable at the individual and at organizational level to our community level and regional level to some of us in the room and at international and global levels to carry over the messages and recommendations from such meetings. We hope that the format of the workshop will help you in this mission, and that by the end of tomorrow, together we'll have learned and exchanged many ideas, and that we'll have been able to identify some key priorities for Tanzania in the next 2 years for science and community to continue working together for the HIV response, in particular in the areas of prevention, treatment, stigma, and reducing stigma and discrimination. Before passing over to the next speaker, I would like to thank VIV Healthcare, Gilead, and MSQ for supporting this meeting. I would also like to emphasize that IAS is a members organization and that IAS members steer the direction and activities that IAS implements. We are currently have 147 members from Tanzania out of close to 15,000 members globally. So we're representing less than 1%. So I think there is a challenge there for all of us to increase our membership here. And so if you are not a member, we highly encourage you to join and have a voice in our global movement and activities. Please note that as participants in this workshop, you are eligible for a special offer of membership, and you may have seen the details on the screen before we started on the table. So if you want to discuss further, and please see the members behind there. That is Joan and Ron, and during the lunch breaks or tea breaks, I will tell you more. I would now like to welcome Dr. Wena Makaora, who will be providing an opening address to this workshop. Thank you for your audience.
Professor Kenneth Mure, the chair of the IAS Governing Council representative for Tanzania, Dr. Sekela Makusa, executive director for AGPAHI, my colleagues who are participating in this workshop. My name is Wena Makaora. I'm working with the National AIDS Control Program, Ministry of Health, Dodoma. I'm standing here on behalf of Dr. Anna Tilebamera, who is the program manager for National AIDS Control Program Tanzania, who was supposed to give this keynote opening for the occasion. Ladies and gentlemen, first and foremost, I would like to thank Almighty God for sharing, for granting us with the health to attend this important day, this important workshop, which is aiming at improving the services we are rendering in our country. And as we know, this workshop will entail to discuss what transpired during the IAS International Conference in Canada in July 2022. And this workshop is also very important for the ministry because it will also give us a way of where we are and what we should do to improve the services. The workshop involves different stakeholders, government officials, NGOs and CSOs. So this is the best forum to brainstorm on what we should do to improve the services. I know we will hear a lot during the course of the workshop, but just to shed a light on the progress, I'll give a short picture of where we are in terms of progress in HIV/AIDS. For example, by June 2022, we have a total of 6,000 AIDS facilities which are delivering service in our country. We also have about 1.5 million people living with HIV who are registered in our clinics. And in terms of progress in the 95, for those who know the HIV status from our program data, we had 91% of people knowing their HIV status. And out of these, 99% were registered for HIV care and treatment. And of those who are ART, up to 96 and the HIV viral load suppressed when they took their HIV viral load test. So you will agree with me, we have made a very tremendous progress in the fight against AIDS. So in this workshop we will talk about innovative HIV preventive services as well as HIV treatment, especially among key and vulnerable population, like adolescents and other key important population. We'll also talk about stigma. So all these will help us to reach our ultimate goal, which is HIV epidemic control by 2030. So I would like to call all the workshop participants to be attentive, to air their views, what they think would help the ministry and the other stakeholders to continue fighting against AIDS to reach our ultimate goal as pointed earlier. So with these few remarks, I would like to say this workshop is opened, and we're looking forward to fruitful participation and have best recommendations for us and the other stakeholders to use in our daily undertakings. Thank you all. Nakaribuni sana.
So I don't know how many people attended the AIDS 2022. By show of hand. We have some good audience here. Who will be the four of you will be my co-presenters. So if, when you're presenting our video, wants to you to expound. How many health providers do we have here? Okay, health providers, policymakers, basic scientists. Basic scientists are lab scientists who work on HIV cure, who work on vaccines. Anybody here? Behavioral scientists, social scientists. Nice. So we are community advocates. So we are a nice mix. So I probably have been told I could take up to 30 minutes, but I will try and take less because I think there were some people who are not able to make it. And I'm going to do the impossible task of sharing the highlights of AIDS 2022 in those few minutes, a meeting that went on for over 3 days. And I'm going to use these toolkits that have been developed by IAS. For those who are IAS members, please go to the website. These toolkits are there for free. They have good notes that you can follow on so that you'll be able to see this. And they cover many topics, and the topics are all listed here. I may not go through them. And this microphone is crossing my neck. So there are slides that summarize what was talked about around vaccine and cure research, ART infections, HIV prevention and sexual health, communities at the center of care, improving healthcare, and economics. I will start, this is news, and I'm sure it also made news in the Ugandan media about the 5th patient to be cured of HIV. And this patient was known as the City of Hope patient. Somebody may ask, why do these patients have names of cities? Most of the times they have these names so that then their identities are protected. And this was a patient who was being treated for leukemia. And he received a stem cell transplant from a donor with a rare delta, that's 2CCR5. And this is a kind of a mutation that prevents people from acquiring HIV, and has been found a lot in people probably in the US, Europe. There are people who may have this rare mutation. So they got this transplant, which you could also call it a bone marrow transplant, and they have been cured of HIV. The 4 previous transplants were against stem cell transplant. There was Timothy Ray Brown of Berlin. I think he probably later died of cancer. Then there will be the London patient, then the Düsseldorf patient, and the New York patient. So they all have names of cities. This technology is important, but it would be very difficult to scale up. Yeah? But what is exciting is that it is possible to cure HIV if you have this kind of transplant, stem cell transplant for those living with leukemia and HIV, co-infected, both having leukemia and co-infected with HIV. If we had time, I know we will not have time at the moment, but there is a link that I will share later on the researchers talking about the City of Hope patient. Another technology, and I don't know whether we have this kind of work, broadly neutralizing antibodies research happening in Tanzania. We have studies, including in my own site, on broadly neutralizing antibodies, and these are being piloted for both treatment and prevention. And the update we got in this meeting is that as a 2018 study, 9 out of 11 people who are given the 2 BNABs that are showed there maintained viral and detectability for were still being off ART for an average of 5 months. This is exciting because once you get your broadly neutralizing antibody, many times they're either given as infusions or subcutaneous. Then for the people on treatment, then they do not need to use ART for 5 months. And this could be a potential tool for treatment. There is also work that is being piloted around using broad neutralizing antibodies for prevention. What about HIV vaccine research? I know there's been a lot of debate, especially now that we got COVID vaccine coming very rapidly. But the work of HIV vaccine research is still on, is still happening, and that's why I was asking whether there are basic scientists here. There's one vaccine, RV144, which had shown modest prevention, which was about like 1% prevention. And there is a modified version of this vaccine, and these phase 3 trials are currently ongoing, and you can look this study up, known as Mosaic. And we're just reminded that as we think about HIV, is that it would take 30 to 100 times more neutralizing antibodies to inhibit HIV compared to COVID. So there are different viruses as we think. But what we have learned and what we had in the meeting is that what has been learned through development of COVID vaccine would also be used to develop more potent HIV vaccine, including the mRNA technology. So there is quite a bit there to learn. So what about treatment? We were reminded that in 2021, that was last year, over 650,000 people died due to advanced HIV disease-related causes. Note that these days we are not talking about AIDS, we are talking about advanced HIV disease. And most of these died because they had interrupted treatment and were restarting. So I think for those health providers who are here, it's important to counsel people not to interrupt treatment, and they died 3 months after restarting. So tell people to maintain on that. And what was killing them was that these are mainly due to co-infections or opportunistic infections such as tuberculosis and cryptococcal meningitis. And I also want you to visit the IAS website to look at the studies that were presented around treatment of multi-drug resistant tuberculosis, that we now have even an oral treatment that can be used. Then on this same meeting, there was a launch of WHO guidelines on treatment of cryptococcal meningitis. As we have said, it's one of the leading causes of death during advanced HIV disease, and it leads to about 15%. And as you can see, in our region, whether it is Kenya, Tanzania, Uganda, and other countries of Sub-Saharan Africa, we are still carrying the highest burden of cryptococcal meningitis and cryptococcal meningitis-related deaths. So in your programming for the policymakers, as you share your resources, think about how to plan for management of opportunistic infections. So what about HIV prevention? This was one of the highlights of this conference. For those who are there again, and probably also this made it to the Tanzanian media, this is one of the first studies to demonstrate the use of doxepep for prevention of STIs. And this was done among people who are HIV negative on PrEP and those who are also living with HIV. It is important to start programming around STIs. The reason being, when people are on oral PrEP, which is highly efficacious, and all other PrEP medications that are in the pipeline, it's likely that they may not use condoms. And this will put them at risk of STI acquisition. And we have seen from some of the cohorts reporting increased upside of bacterial STIs. So the key point here is important to start thinking around that. And what this study showed us is that people were given a single dose of doxy, 200 milligrams, soon after sex, less than 72 hours after, just a HIV PEG. Yeah? And we were able to see that, that there was a significant reduction on all the 3 STIs among both HIV infected and HIV uninfected persons. I want to pause right there for us to absorb, for those, especially those who are not in the conference, to start thinking about how can this fit within our policies? How can we start thinking about programming for STIs? That we are not only thinking about PrEP for HIV, but we're also thinking about PrEP for STIs, even for people who get, accidental exposures, that, as we know, they can also use. So this was a key highlight, and there's also a video about it that probably we'll share with a link, so that you can also be able to get more details on this specific study. And as we get into our groups, we can start thinking about how we absorb some of these kind of studies. This conference, though it's a HIV conference, could not have missed the issue of the monkeypox. Monkeypox is one of the current diseases that is currently being discussed a lot and has been endemic in West and Central Africa, but there has been an outbreak. I think we currently have over 23,000 reported cases, and there have been also outbreaks in non-endemic countries such as Europe, North America, including Canada, but these were being seen around men who have sex with men, and about 10% of people get lesions around the anogenital region. So since the vaccines that are protective against monkeypox, it was important that there was a call to enable vaccines to be available in these regions, and there's a lot of programming required around monkeypox and a lot of education. I don't know whether this is one of the hot topics in Tanzania, but it needs to be talked about before we are starting to get cases. And we know the transmission mechanisms, how it's transmitted, how it's protected, prevented, and it's very similar to other infections, including contacts. Then, most of my work has been mainly around oral pre-exposure prophylaxis, and I was happy to see this WHO technical brief round on differentiated and simplified PrEP delivery. And I would also encourage you to go through this and see what has been advocated, including issues of self-testing during PrEP delivery. So again, this was a key document that I will probably not go through it, but it's good to, as you're thinking about PrEP delivery in our countries, we started delivering PrEP. I don't know whether it's the same case in Tanzania, in HIV clinics only. But what differentiated and simplified PrEP delivery means is that we need to move out of the fixed, usual delivery mechanisms. We need to start thinking about how do we deliver PrEP in other places. Like in Kenya, people access, 45% of people get their regular care from pharmacies. Could pharmacies be one of those? Could we do multi-month dispensing for PrEP with self-testing? Again, those are some of the things that we need. Could we then work with peers? Could we do telehealth to deliver PrEP so that we're able to reach as many people as possible? This is one of our studies, and it was published. The first phase of the study was published in Lancet HIV, but that was for the first 6 months. And we also have now this analysis that was presented in AIDS 2022. And this was because currently PrEP in Kenya is delivered in HIV clinics with quarterly visits. And the reason why people come for quarterly visits is because of the HIV testing. They need to be tested every 3 months. And we had a randomized clinical trial where we randomized people to the standard of care, and then we had extended visits. Rather than coming every 3 months, they were coming every 6 months, and in between they were given an oral or blood-based HIV self-test, which would, I think there would be advantages for that because you're reducing the burdens to the health care, but you're also reducing the clinic visits burdens to the patients or clients. What we are able to see from this specific study is that this intervention was non-inferior to the current standard, meaning that it was equally good, in simple words, that you could actually use HIV self-test to spread the disease without compromising the testing, because they reported was still testing, without compromising retention and without compromising adherence. But what was more interesting in our study is that we were able to see almost a 2-fold increase in adherence among women who are not in serodiscordant relationships, that they were able to adhere better. Probably because they did not need to come to visits, they were able to take drugs at home, etc. And for those who in the HIV field work, especially in oral exposure prophylaxis, women who are not in serodiscordant relationships have been among the populations that have faced the biggest challenge in adherence. And what our study is showing us, that probably some of the barriers to adherence is this regular visit, this coming to the clinic. So if for some of these, if they are able to get HIV self-testing, they probably adhere better. So as you're thinking about the differentiation, think about how do we then, for those who do not need to come for visits, how they can use HIV self-test kits. Then there was a study that was presented about nurses being trained and supported to prescribe PrEP. In many settings, nurses are not allowed to prescribe PrEP, but what this is showing is that working with nurses to prescribe PrEP, to initiate and prescribe PrEP, work quite well, and were able to reach populations such as sex workers, even better than the doctors. They were able to reach those who inject drugs, higher numbers of those who inject drugs, even more than the doctor prescriptions. The take-home message here is, as we think about scaling up PrEP and other prevention intervention, it's important to start thinking of task shifting, so that you are able to work with other trade providers to prescribe PrEP. Then again, thinking outside the box is working with peers, and this was a peer delivery model that happened in Ghana, where they worked with peers, and this was quite important. And I know there are studies, including in our own projects, where we are working with peers to reach other peers, either for recruitment, to pass HIV self-test kits, so that people can test and know their status. If they are negative, they go for PrEP. If they are at risk, if they are positive, they go for treatment. So this is another model that we could think about in our countries in sub-Saharan Africa, including Tanzania. And then again, thinking about telehealth, and this was very, very important during COVID. I don't know how much of telehealth was done, but it's also been worked through thinking about telehealth. That is one of the building blocks of the where, rather than people coming, you get this through telehealth, where people, complete their evaluations online, and they get their PrEP delivered by a courier to their homes. And usually what happens is you get PrEP delivered and you get your self-test, and you then mail the results. And now because of STIs, in some of the countries where telehealth is being piloted, they are also getting STI self-swabs. So you get your swab, you get your test, you get your PrEP, and you send your swab back with the courier. And then you are informed whether you have STIs. These are things that can be done. I know in our setting in Kenya, we're also piloting use of telehealth to deliver PrEP. I don't know how much of that is being done in Tanzania, but we'll hear a bit more. Then, the other thing that we want to talk about is about, there was a lot of research presented around long-acting PrEP, and one of the the reasons why long-acting PrEP is important is because there are many people who are not able to adhere. If we were to raise our hands here, how many people complete just a 7-day course of antibiotics, you'll find probably a third or maybe a 50%. So you can imagine PrEP month after month after month. There are people who may face challenges, and that's why there have been talks around this longer acting product, and one of them being the cabotegravir injectable. And also, we were also reminded at the conference that in 2020, only 28% of the target 3 million in low and middle income countries had been able to access PrEP. So there is need to diversify. Just like in the field of contraception, where we have multiple methods to cater for different preferences, there is need to think about injectable. And there have been trials, that one of them is HPTN 083 and HPTN 084, and you probably look them up. They are the first studies to show that cabotegravir injectables are safe and superior compared to oral PrEP. And the superiority arises from the law that when you look at injectables, you don't need to adhere. So that's why it's been demonstrated to be superior. And what we are able to see in the trials is that initially we are able to see 80%, but then superiority compared to oral PrEP. But when now people knew that they were not on placebos and what we call an open label extension for a year, we were able to see even higher superiority of 84% or 89%. And even for those who got HIV, the 3 cases or so were those who did not go for repeat injections. So, take-home message is that cabotegravir works, is more superior to oral PrEP, and I'm sure there may be some discussions within your NAC and your NASCOP equivalent around programming for cabotegravir, because it's going to reach very many people. And remember, longer acting products are not only for prevention, even for treatment. For those working in the field of HIV treatment, one of the biggest challenges, and one of the biggest challenges as we've seen as a leading to advanced HIV disease, is for people who interrupt treatment. But once people are able to get injectables, and these injectables are currently 2 months, then they may be also probably having some that have been piloted at 6 months and will go beyond, is that they will be able to reach people who have challenges in adhering to oral formulations. And we hear this a lot. And we have listed some of the barriers that have been shown to interfere with the oral adherence. And probably again, this will lead to both treatment failures and work very well among some of the populations, including some of those who are not able to adhere because of even their mental status, some of those who are in school. I know some children, when they go to boarding schools, their adherence, this is a challenge. For those who may need to use ARVs discreetly, injectables may work very well for those who are homeless. So there's a lot of work to be done around this. Then the other product, again, that's still being discussed a lot, and that some of our teams and we ourselves have worked on, is the dapivirine vaginal ring, that will be available soon. And there have been a lot of studies that have shown that in open label extension, that it works, it's quite efficacious. I know there were concerns in trials, again, where we are seeing efficacy of about 50%, a maximum of 60%, but as people get to know that it works and they're able to keep it in, then we're even able to see higher prevention rates, higher efficacy. So it's important, again, to start thinking about the prevalent vaginal ring, because there are people who cannot stand injections, there are people who cannot stand oral PrEP, but they probably would want a ring that they put and forget it for a month. There are development, and there have been studies around 3-monthly rings, because the current dapivirine vaginal ring is a monthly ring that is changed every month. But there is research that has been presented around 3-monthly rings. There's also work that has been shown about adding contraceptives to the ring, so you end up having a multi-purpose technology ring being used. So let's start as in our country, start thinking about this, and this was some of the things that were reminded during AIDS 2022, that we need to start programming and thinking around the appearing vaginal ring. The other key message that was discussed in AIDS 2022 is about You Equals You. How many are familiar with You Equals You? The campaign? Good. How many are convinced? This is a great challenge. This is a great challenge because we are saying undetectable is equal to untransmittable. When people get virus suppression, they cannot transmit HIV. There is a documented case of sexual transmission of people who are virus suppressed. This message is so strong because it tells us that treatment is a potent HIV prevention tool. But if it's not, health providers are not convinced, they will not be able to transmit this information to their clients. And some of the clients, including those who are in several contact relationships, this would be an additional motivation for them to adhere to protect their partners. And as you can see, there are surveys that have been done in different countries. This was done in Asia among 15,000 people, among who 6.8 were positive and 46.2 were negative. And you can only see that about 36% were aware of You Equals You, and 44.8% had never heard about it. Almost two-thirds. I'm not too sure if we did this survey in Tanzania, how many people would have heard about You Equals You. So, kazi kwenu, kazi kwa NAC, kazi kwa NASCOP, kazi kwa community members to think about how to inform people, to include kazi kwa counselors, to see how do you incorporate this message of You Equals You in counseling both HIV infected and even those who are HIV uninfected who could have HIV positive partners. And one of the key things from this slide is that health providers have a big challenge when communicating the message of You Equals You. So there's need for training. There's need not only for this. One of the studies we did in Kenya also, which was presented in Ariel IAS, was that there is lack of deeper conviction. You may be aware of You Equals You, but you're not convinced. So if you're not convinced, you'll not be able to convince others. So this was a key highlight message of You Equals You, and it's also going to, I'm sure it's going to feature in many IAS conferences. So keep looking at this, keep learning from IAS conferences on how to communicate the message of You Equals You better. There was a lot of talk again, and there are many presentations which I may not cover today, about putting communities at the center of the HIV response. As you're thinking about working with communities, it's important that you know and come up with creative ways of working with communities. We are thinking about, the Director General of UNAIDS talked about anti-racism and decolonizing the AIDS response, and then including the indigenous people so that they're able to come up with interventions, working with key populations. So there were many presentations and experiences from all these countries. And I would encourage you to, again, get the complete toolkit. Again, I take this opportunity to let you know that there were new WHO guidelines launched on, for HIV, hepatitis, and STIs for key populations. This will be again for all of us who are here to look them up, and of course for NAC and NASCOP, because then, like it happens in my country, when WHO launches guidelines, we take the guidelines and we customize them to our local needs. So this is to alert you that these guidelines are already there, and probably I'm sure you have taken them up. And then just also to remember that there are key items as we think about the drugs that I've been talking about, both for treatment and prevention. It's good also to think about these other social issues like gender, equity, human rights, community leadership, and looking around investments to ending HIV. So it's not only thinking about all this, the science, but you also need to think about all these things so that we can be able to incorporate them so that we can meet the current targets and we were reminded at AIDS 2022 that no country has met 95, and indeed the 1990 target. And part of the challenges have also been around adolescent and pediatric populations in some of these countries, where you'll find that probably the third 90 or the third 95 has been a challenge. So as countries, whether it is in Tanzania, thinking about how, if we have not met the 1990, how can we work around meeting the 1990 so we can hit the 1995, and looking at countries share their experiences. And so these conferences are usually quite good because then we learn the strategies countries are working on. Then there's been a lot of monitoring that happens around from donors, from governments, from many other people. But the key message that I took home personally from the AIDS 2022 is the importance of community-led monitoring. And there was a tool that was shown, and looking at how communities can work to monitor the indicators, and these indicators are the ones that will be relevant to communities, and this would help improve services. So for the people who are from the community sector here, who are doing community work, know that there is need to look at this presentation in detail so that then you can understand how you can work together to monitor the HIV response, and that the people who are policymakers here should be able to give you space for community-led monitoring. So then as I come towards the end of my presentation, is that there was a lot of talk about differentiated service delivery for HIV treatment and prevention. And when you're thinking about HIV, the building blocks for differentiated service delivery, you think about when, where, who, and what. And you can see all these details on the slide of when you think about when. This is where we are saying multi-month dispensing worked very well, even for both treatment and prevention. And who are pushed to this space by COVID. Where, let's move away from the traditional health facilities and think outside the box on how we can work with primary healthcare facilities, pharmacies, other spaces, including mobile vans that were shot from South Africa and other places. Let's do task shifting when we think about whom, and then we think about the fourth component, which is what, where we are thinking about looking at issues of refills, initiation and refills, being creative around that, being creative around lab tests, social support. So thinking about how the whole package, how can we simplify that package? Again, I believe I'm preaching to the choir here, where I say that mental health conditions are key. They influence uptake and continuation of both HIV prevention and HIV treatment. Whether somebody is depressed, whether somebody has anxiety, whether somebody has PTSD, that is key. And yet, there has been a real challenge of incorporating these services. There was a big survey that was reported in at AIDS 2022 among 223 clinics in 41 countries, where 67 were urban and 78 were in the low and middle income countries. The key point here is that the screening was very low. As you can see, for depression, only 50% are screening for depression. Yet screening for depression, what do we need to screen for depression? Or the clinicians, or psychologists, or counselors? Simple tools. Some of them are paper tools. Yeah? PHQ-9 can tell you whether somebody needs further evaluation. Yeah, and we have all simple. For anxiety, we have tools that can be used. Yet people are one-pagers. In fact, for depression, you could even have, leave the PHQ-9, you could even have a PHQ-2. Yeah? To just tell you. And the others even around suicidality. And this has been a real issue for adolescents living with HIV. So when it's important. And then for medication in these clinics, again, to treat depression, to treat anxiety, to treat post-traumatic stress syndromes is again very few. So a take-home message again for policymakers, for clinicians, health workers. Even if it's not policy, I think a PhD 9 would be so easy to administer as people are waiting to be managed. Then this is actually my last slide. There was also a huge call of making cabotegravir. We have said very nice things around cabotegravir injectable, how superior it is, up to 89% compared to oral PrEP. The biggest challenge though has been the cost. And for it to work, costs have to come down. There have been a lot of talk. There have been, the VIF company has been committed to supplying countries that were involved in the clinical trials. There are 14 of them. There have been licensing and patent release for some of the countries, and these countries are up to, I think there are actually 90 countries got the patent to sort of also get generic KBLAs. So there's need to keep pushing the cost down for it to work. And also bring countries that are not covered within this patent, and they are listed here. And there was a huge call to a lot of advocacy around making KBLA cheaper. So sorry, I know I've taken a lot of time, but all these are very relevant discussions, and we will probably welcome questions. We have time for questions. Dr. Sekera, maybe one or two burning questions or contributions from my co-presenters, my four co-presenters. If there's something else you saw that you want to add, please jump in. Yes, this was like just a snapshot. Pass the mic. Everybody pass the mic. Yeah.
Thank you very much, Professor Ure. I have actually two comments and two questions. On the comments, I'd just like to reconcile between the 1995 you spoke about and what I hinted in my speech, just to keep people on page. Because we have two sources of information, and what is measured for a country's success is through population-based surveys. So, colleagues, you agree with me, looking at our S facility data, we get 90s, 99, in our 95, 95, but the standard measure of where we are will be through population-based survey. For our country, it will be this year, and it is started. So we will have results for the second Tanzania HIV impact survey. So we shouldn't mix those two things. For example, for Botswana, the results they presented was through the population-based survey. But if you look at the facility data, you definitely find more than 95. So those information should be interpreted very carefully. Second, you said it very right, and the ministry is on the track about STI. I'm very glad that you mentioned we are focusing on STIs and hepatitis as also our main focus in addition to HIV. But two questions. One is on, you spoke about advanced HIV disease-related death, and looks like it's a pooled result from different countries. I just wanted to know, how did you come about it? And if Tanzania is one of the countries contributing to that, because we can't establish this using program data unless it's a modeling exercise. Two is on DPV. We know NNRTI has a very high resistance, and one of the things which people worry about is resistance to. So probably, if our countries want to adopt this, we should clear the air about resistance and any other noises around DPV. So those are the observations out of your presentation. Asante sana.
Asante. I think if I could jump into those, I think the issue of HIV-related deaths from advanced disease, the 650,000 deaths, which is works out to a death per minute, works out from UNH data, and we'll probably be able to go and visit that page better and see the details. But usually, UNH works through some program data, modeling. So it's a combination of a lot of things. That they even look at ART coverage. And as we are talking about the 1990 or 1995, remember that some of the countries may end up, there are regional differences, even within countries. There are also population differences. So as we think about what when we are calculating the 1990 or 1995, let's also remember that countries, for example, some of them would do very well even among adult population, but then the adolescent and pediatric populations pull those down. So the aggregate becomes a problem. But I think these are good debates to keep having. The prevalent vaginal ring has there's a lot of studies that have been done, and one of the key things is a topical product. So the amount of drug that goes into the system is not much. So, and currently the studies that have been done they have looked at the issue of resistance, and we have not seen much resistance yet. So, and I'll be happy to share some of that data with you from the MTN Microbicide Trials Network that did MTN 020 and MTN 025, known as HOPE. If probably anybody wants to look at those before I share anything, just look at MTN 020 and MTN 025. The lead author for those was Dr. Jared Byton, and they have also talked about resistance. And that's the beauty of a topical product. The amount of drug that gets into the system is not much. So even if you get a breakthrough infection, then the issue of resistance is not as much as you would face with a systemic product. Any additional question, comment? Anything I missed? This is a biased presentation based on the slides I picked.
Thank you so much for your presentation. I think I can be loud enough, no? This is good? Okay. Thank you so much for your presentation, Dr. Ariel. I think it's a very good summary. This is good? Okay. I just wanted to provide a bit of a comment on the long-acting paediatric. I'm here representing the Medicines Platform Pool, which is an organization that was mentioned. Sorry, it's distracting. It's one of the organizations that was mentioned in your presentation, specifically as concerns long-acting cabotegravir, which was one of the very exciting things that was announced at IAS, including the license that Medicines Platform Pool has entered with big healthcare. Just to give a bit of an update, Medicines Platform Pool is now already in the process of selecting generic manufacturers for cabotegravir long-acting. We are thinking that we'll have about 3 licensees for generic cabotegravir with a timeline of about 3 to 4 years of availability of the product in low-income countries, around 90 countries, including Tanzania, of course. There's still a few issues to discuss. There's some advocacy around the countries that were left out of the license that are LMICs. However, it's important to note that about the countries that are in the license cover at least 90%, more than 90% of people living with HIV. So we're trying to find a way between now and the 3-4 years where the generic product will be available on the market to see how best we can work with other partners who are working on the advocacy space to see if we can extend the territories, but also to see if we can get the originator products to be provided to these countries between now and the 4 years that we anticipate that the product will be available from a generic perspective in country. And just to flag that the voluntary licensing mechanism has had very good results. I mean, Tanzania, just with dolutegravir and dolutegravir containing regimens, since 2018, Tanzania has received about 50 million doses of dolutegravir through MPP's voluntary licensing mechanism, and we're very excited about the new partnership with Big Healthcare for Kabele.
Thank you. That's very exciting news. I think for us who are in the prevention space, I think that's very exciting to hear that we'll be able to in the next few months, probably, we'll be able to get products. All right. Any question or final question? I know we don't know how we are doing on time. We can carry on.
We are not doing well with time.
Oh.
Maybe we can have one last comment and then we continue the next
one last burning question or comment.
Thank you. I just wanted to add something that I saw, maybe I heard or I thought while I wasn't attending international.
Can you please identify yourself before you start speaking?
Okay, thank you. My name is Cyprian Skomba. I'm working with the Network of Young People Living with HIV and the Global Network of Young People Living with HIV. While attending the International AIDS Conference, among the things that was really emphasized was about the ethical and meaningful engagement of young people. And the Global Network of Young People launched a guideline called We Matter Value as guideline. That guideline highlighted a lot of things about how to partner and work with young people to accelerate HIV responses. And also the guideline, throughout the guideline, you may find out our stories, experience, and preference on how we think we need to be engaged to accelerate the HIV responses. And we talked a lot about the things like how do the organization working to address HIV partnering with us. They are looking at us just like as in numbers. They're looking at key population just like in numbers, or they're looking at them as the partners and the beneficiaries. So we have also talked a lot about the We Matter Values guideline. And also, there was an issue about self-care among young people living with HIV, and the recent guideline launched by WHO on self-care to the people living with HIV to understand how best can they navigate. And the issue around the NCDs, because it seems like nowadays the HIV is not killing anymore, but the NCDs are the one leading to more challenges to most of young people and other people living with HIV across the globe. So there were also some guidelines being presented and also launched during the International AIDS Conference. Thank you.
Thank you very much. I think that's a great addition. And then during tea and during our breakout session, for all those who attended meetings, as I've said, mine was a very biased 15 minutes or 15-20 minutes, so please feel free to keep adding. Become members so that you can access some of these tools and get to know all that was discussed. So thank you very much for your audience, and we'll keep discussing.
Yeah, my name is Mohammed Toure, and I work for the UNAIDS country office here in Tanzania. And I'm here to present to you this snapshot of the Global AIDS report. As you may have heard from the previous speaker, this report was also launched in July in the International AIDS Conference in Tanzania. And it provides quite very good highlights in terms of where we are with the AIDS epidemic at the global level. The report basically is a synthesis. It's a data-driven document reflecting data that has been put together by countries all around the world so that we can see the progress that we've made in the AIDS response. And Tanzania has been part of those countries that submitted data this year. But it's important for us to note that this data is not reflective of 2022. It's reflective up to December 2021. And we have colleagues in here who were part of the process, the Global AIDS monitoring process here in Tanzania. We worked very closely with them to put together the necessary data sets for Tanzania. The report has been dubbed in danger. You start to wonder, why is it dubbed or described as in danger? It's described as in danger because the key indicators that we are looking at to tell us the status of the global AIDS response seems to suggest that we are largely not on track to achieve the 2025 targets. It's as simple as that. This doesn't mean that we haven't made progress in other areas. We have. But in terms of having epidemic control, which largely has to do with incidents and which largely has to do with new infections, we are very much challenged in that area. And we'll see those details. The report, as my colleague there said, is a snapshot. It's not very detailed. But I'm very much impressed by what is coming out of this discussion. Although we've not really gone too far with it, but I see a lot of complementarity between the various presentations. Hence, we have deliberately made this report a snapshot and a very short one, so I'm not going to spend too much time on it because I know we're not doing very well on time and there are many people who are going to be coming to make their own presentations. So, I want to start with highlighting the 3 key indicators. Most of us here, as a preacher, as the previous presenter said, we're preaching to the choir. We're very much conversant with these indicators and their data sets. People living with HIV. From the analysis carried out, we have 38.4 million people with HIV globally, and new infections as of December 2021 was 1.5 million. And deaths due to advanced HIV diseases, thanks Professor for letting us know that, is 650,000. So these are the 3 key indicators here. But I want to isolate the second and the third set of indicators. Because that one links very much to the title of the report, In Danger. Because the new HIV infections are very much critical for us at the country level and globally, for us to be able to tell where we are in terms of managing the response very well, or in terms of telling us whether our prevention interventions are working very, very well. So let's have a look at the trend in new infections since 1990. As you can see, new infections peaked between 1995 to 1997. And since then, it's been going down consistently. If you look at that, you might say, well, what is the deal here? New infections are going down. But the problem here is that the rate of decline is not what we want. And because of that, the HIV epidemic is in danger. As you can see, the targets there for 2025, and looking at the trend, we are not on track to hit that target. So it's an issue. It means our HIV prevention interventions are not delivering as much as we would like to. Let's take a much more detailed look at the figures here. It shows that there has been a slowdown in decline in HIV infections overall. And new HIV infections have only fallen by 32% since 2010. We're taking 2010 as a baseline because that is around the period when many countries really put together a very organized HIV response, when they had their strategic plan, and when they started monitoring of the epidemic. In Eastern Europe, Central Asia, Latin America, Middle East, and North Africa, there is an alarming increase in rates of new infections. Before this time around, we thought that these countries were really like one of the countries that will achieve epidemic control, but there has been a turnaround, and we've seen new HIV infections rising in these countries. And adolescent girls, somebody mentioned it just now, adolescent girls and young women account for about 4 in 5 of new HIV infections among young people in sub-Saharan Africa. And so many children are still being infected. So the response is in danger. Further, about 4,000 new infections are happening every day. That is what the analysis showed. And 58% of that 4,000 are in sub-Saharan Africa. And about 430 are among children under the age of 15. And the remainder, 3,600, are among adults 15 years and above. Let's have a look at the death due to HIV-related conditions. Here, we are not doing as bad as it's happening with new HIV infections, which means that treatment programs are working much better than the prevention programs. And treatment products are more efficacious. They are getting better. See how the trend is. We are much closer to our target for 2025 than we are closer for new infections. But notwithstanding, more work still needs to be done if we need to achieve our targets. So the analysis shows that ESA bears 43% of the 650,000 deaths in 2021. And although on the decline, the current trend will lead to 460,000 AIDS-related deaths in 2025, which will be 23% above the targets. Because we're supposed to have fewer than 250,000 deaths by 2025. But what we are seeing here is that we will be around 460,000. We can't do justice to this presentation if we do not isolate children here and talk a bit about them. We're having about 1.7 million children living with HIV globally as of 2021. And new infections still persist in children, 160,000, and deaths due to AIDS, 98,000, as at December 2021. So, another very important revelation that came out of the analysis is how the new infections are distributed across different population groups. We have been paying quite significant attention to key population groups, which include sex workers, people who inject drugs, gay men, and transgender. But we've seen this time around an emerging population that is coming out of the general population that is of concern. And those are clients of sex workers and sex partners of key populations. These are people like me and you who are part of the general population. And that is where we are seeing quite a significant amount of new infections registering. Look at that, it's 25%. And compare that to the key populations. It means, over the years, our refocus on key populations seems to be working. We are not there yet, don't get me wrong, but things seem to be happening at the expense of certain other hidden population groups, which is emerging now in the analysis. For sub-Saharan Africa, it's still the same, it's even higher, it's 26% of clients of sex workers and sex partners of key population. A study was done sometimes in Thailand, where housewives were just getting infected and the prevalence was going up. They realized that their husbands, who were bisexual, going out with other men, will come home and infect their wives. So we are seeing this happening now, again. So this is how it looks for sub-Saharan Africa. and for the rest of the world, is still concerning. So let's see how adults and children estimated to be living with HIV also is distributed across the globe. What I want to highlight here is that our region, the Eastern Southern African region, bears the brunt of the epidemic. Out of the 38.4 million, we carry 20.6 million, which is about 50 or slightly over 50%. That is huge. We are still the epicenter of this disease, or of the epidemic. So for new infections, we still bear the brunt in terms of percentage. 670,000 out of 1.5, about 50% here again. AIDS-related deaths, ESA is still the epicenter here. 280,000 out of 690,000 deaths due to AIDS-related diseases. For children, it's the same trend. For new infections for children as well, we're seeing the same trend. And for AIDS-related deaths, it's the same, ESA. So we are really in the limelight, and so much is expected from this region. So in summary, you see the global totals down there. So for people living with HIV, we are bearing the brunt by 54%, and for new infections, ESA is bearing 45%, and for deaths due to AIDS-related diseases, 43%. Let's come back to treatment. Let's come back to the treatment aspect of it. Here, globally and at the country level, we are really doing well. You heard what our colleague from NACP said in terms of the 95, 95, 95. The figures have really improved if we using the program data. Globally, 85% of people living with HIV know the HIV status. 75% of people living with HIV receive ART, which represents 88% of those who know their HIV status. And 68% of people living with HIV achieve viral suppression, which represents 92% of people on treatment. This further endorses the efficacy and efficiency, I would say, of our treatment programs. For this, we are largely on track to achieve the 95-95 targets by 2025. This is important because it puts us on track to achieve epidemic control by 2030, as was earlier said. And it puts us on track to have, I would say, to witness an end to AIDS as a public health threat. Because if you are suppressed, it becomes very difficult for you to infect. So, what are the other issues, again, that were highlighted in the report? We have heard of the 10-10-10 targets, which are critical to reduce barriers, which include structural barriers across health and social services. Of course, the first 10% has to do with having less than 10% of countries globally with policy and legal environments that limits access to HIV services. The second 10 has to do with having 10% of people living with HIV and key populations free from stigma and discrimination. And then the third 10% has to do with gender-based violence and inequalities, having 10% of people exposed to gender-based violence and general gender inequalities. So out of that, the coverage and use of combination prevention, HIV prevention among gay men and other men who have sex with men and transgender people was low, okay? And I mean, of course, I skipped this one. Only one country met the target of women making their own decisions, and no country at all reported achieving near absence or less than 10% of discriminatory attitude. This is really very key. And over 1.6 million people worldwide were receiving oral PrEP. This is very encouraging, having heard from our previous presentation. So progress towards VMMC. The target is for 90% of target countries to have boys and men voluntarily circumcised. This varies among the priority 15 countries, according to the data. Data provided indicates that Kenya is the only country that has achieved the 90%. But of course, we are all aware that Tanzania is one of those countries that has done remarkably well in terms of being on track to achieve the VMC target. Tanzania and Ethiopia were also the second country that stood out as being on track to achieve the 90% target. 82% of pregnant women living with HIV received ART. Coverage among pregnant and breastfeeding women, however, has not meaningfully increased since 2024, particularly in Western and Central Africa, where they were at in 2021, they were at 60%, which was far below the 100% required to be achieved by 2025. Limited information that is currently available suggests that considerable work is still needed to achieve the 80% community-led service delivery target for HIV prevention services for key population. There wasn't much adequate information to do those analyses, but that indicates that there's not much happening in country. And coming to the issue of finance, domestic sources accounted for 60% of resources available for the HIV response, and the United States continued to be the biggest donor and reliable donor for external funding. Bilateral assistance from other donor countries fell by 81%. So this is a wake-up call for countries who are solely dependent on, particularly on PEPFAR. A very, very slight change in PEPFAR funding could bring about disastrous consequences in most of our countries. And domestic resources have increased by, but important to note that the domestic resources have increased by 25% in the last decade. The 60% was just for 2021. But in the last decade, in the last 10 years, domestic resources have only increased by 25%. That is not enough. Of course, Global Fund resources were very important over the past 2.5 years during the COVID period to ensure that countries were still able to provide services during the COVID times. So, having heard all this, what do we need to do? UNAIDS and other development partners have been working together to ensure that certain things are put together to bring us back on track, particularly in the area of prevention. We've heard of the Global Prevention Coalition, the GPC. We've heard of the Global Alliance to Prevent Pediatric AIDS. These are all initiatives that have been tabled to ensure that, particularly prevention, is brought back on track. So now we have a new global roadmap for 2025 with 5 key building blocks. The first one lays 10 priority actions that countries must take to resolve remaining gaps and rebuild momentum in HIV prevention. And those are the 10 points. And the second one emphasizes the need to end inequality that fuel HIV epidemic and hold back efforts to end it. Inequalities create vulnerability, and vulnerability exposes people to new infections. It's as simple as that. So the roadmap also stresses vital roles of community-led action to implement program at scale, meaning that government alone cannot achieve the targets. Communities need to come in to shoulder certain important responsibilities. And the roadmap also calls for discontinuing investments in interventions that are not producing good results. Let's invest in interventions with very high impact. And the roadmap also highlights the importance of sound management and accountability processes of multi-sectoral prevention responses. This, I think, is my last slide. And I want to thank you for the opportunity. Thank you so much.
Thank you very much. Thank you very much, Mr. Mohamed Toure, for the reports. I'm glad that you have explained to us why it is called In Danger, because it was kind of scary. Why is it in danger? So we would allow one burning question, because we are way behind time. If you have a burning question or comment, just one, and then we go to the next presentation. Karibuni. I'm not seeing any hand raised. Can you see any hand raised, Mr. Toure, on that side?
This one there.
Okay.
Yes,
Karibu, Matthew.
Thank you, Mohamed. I think critical to global response and coming back to what we do in Tanzania is meaningful engagement of people living with HIV. And this goes back also to the presentation done by the professor. And it's necessary that countries, implementing partners and the government, responsible departments, to sit down with people living with HIV, key populations, and those groups which are in danger, to strategize on how to meaningfully engage people living with HIV in the HIV response. And one of the approach recently which we used is through the implementation of community-led monitoring. I was pretty fascinated by the presentation from the professor on how to engage beneficiaries to monitor service provision and putting them at the center of service provision through various interventions in differentiated service delivery models. Thank you so much.
Thank you for that comment.
Thank you very much. Can we clap for Mr. Toure as we invite our next speaker, who is coming from TACAIDS, is Dr. Sumba.
Good morning, everyone. Thank you so much, Dr. Sekela, for these very kind introductions. My many thanks to you, dear participants, but also to the organizing committee for having me here to share with you the overview of the HIV response in this country. I will basically be giving a comprehensive kind of key high-level messages in the response, and I want to be touching on the program progress. I believe my colleagues from NACP later in the course will come and share with us the progress we are making in terms of specific intervention areas. Yes, please. By the way, let me say a few things regarding my presentation. We'll be sharing with you data from mainly 4 or 3 sources. Number 1, we are using the spectrum model, the UNAIDS model for 2021, which usually is prepared every year, and those results are ready for sharing by March every year. So, but also we are going to use the program data to show how the programs are performing, and this will be as of December 2021. And these are published data, that's our official data that we're using. But also we'll be supplementing with some survey and surveillance data to show the overall picture of the HIV response in this country. I'll basically be focusing on 3 strategic areas. Number 1 is the strategic focus for the response, but also provide an overview across all the spectrum of the response, but also some of the key challenges that we face as a country as we move forward in controlling the epidemic. These are the strategic focus for the response. Number 1, we want to reduce new infections across all the population groups, but also we want to reduce AIDS-related mortality in all the population groups, but also we want to reduce stigma and discrimination to 0, because they affect services uptake, but also treatment uptake. Now, where we want to be in the next 3 or 4 years, these targets as indicated in the strategic plans, the national sector, but also the health sector strategic plan. So we are saying by 2025, we want to reduce new infection by 85% from the baseline of over 100,000. Currently, we are at around 54,000 new infections. But also the other key result area that we want to achieve, we want also to reduce the final mother-to-child transmission to less than 4%. Currently, we are struggling. We are at around 11%, which means in every 100 HIV-exposed babies, at least 11 children become infected with HIV, something that shouldn't happen in this current era. But also, we want to reduce death by 80% from the baseline of 2020. And as of last year, the number had gone to around 28,000. So in terms of death, we are doing very well. As a country, we are reducing the number of deaths at a reasonable speed. The only challenge that we have is, as Mohammed indicated, in Africa, we still have an issue to do with the new infection. The speed at which we are reducing doesn't give us the space to control the epidemic very soon. But also, we want to reduce stigma and discrimination to less than 5% from the baseline of 2013, where we had the 2080 and 20% for internal and external stigma. So overall, as a country, we have about 1.7 million people living with HIV, and among these, 1.6 are adult men and women, and about 2/3 of these people are women adults, and around 6% are children aged between 0 and 14 years. And the incidence is estimated that in every 100,000 non-infected individuals, at least 96 people are becoming HIV infected. And for last year, the data that we're using currently, we estimate that around 54,000 people were newly infected in 2021. And of these, about 2/3 are women adults. So we see the burden is still among this group of the population. But also we see that closer to 1/3 of the new infections are happening among adolescent people, that is, young women and young men, aged between 15 and 24 years. And the most important thing for concern, among these young people, about 3/4 of the new infections among adolescent girls and young women. Because we have some programs to address the issue of vulnerability among AGY, but the programs perhaps are not that much comprehensive across all the parts of the country. I think it's an area that we need to focus, both in schools but also those out of schools. And as I indicated earlier, one of the areas that we are doing not very well is on the final transmission for mother-child transmission. As I said earlier, around 11 HIV export kids are becoming HIV infected at the end of breastfeeding. Just to reiterate on what Mohammed presented, this is for sub-Saharan Africa, where we belong, in a population of about 1.4 billion people. The majority of the infections, about 2/3, are from the general population. So the key message I wanted to bring up that much as we are focusing in these other vulnerable groups, we should not forget about also the general populations. Because it's all part of the, who is the client of sex worker. Mohammed reiterated, it's the general population. So let's focus in all of the groups, make sure that we prevent transmission of new infections. So this estimate underscores the overall trend in terms of new infections. In the early 2000s, we had around 104,000, but we have been decreasing in terms of the new infections, specifically after the 27, we see there is a somewhat promising kind of decline. But as indicated from the global perspective, it's an area that we are not doing so well. We'll see as we move forward. This is the vertical transmission, the mother-child transmission. As I said earlier, it's an area that we haven't done so much well, and we need to focus, because there is no reason at all why should children still be infected while we have all the skills and the tools to prevent those new infections. This shows the distribution of the HIV prevalence across all the regions in Tanzania mainland, and we have a much higher burden in the southern highlands, a region of Mbeya, Iringa, and Njombe. But something of much concern for us is the burden of the disease among these age groups between men and women. We see that between the age of 15 and 49, the prevalence is about twice among females compared to male, but also between 15 and 24, the AGY, the burden is around 3 times among females as opposed to male. And for the young, 15 to 19, it's about twice among female. And between 20 and 24, it's about 4 times higher. So overall, you have much more burden among females as opposed to male. So that indicates the risk of HIV is much higher among these young groups. So much as we focus on preventions, there is a need to focus much more, especially among the vulnerable groups, in particular among AGY. This also tries to give us a picture on the key and vulnerable populations in Tanzania. The last study we had was of 2017, but of course there are other studies that are being implemented, and I think they have started disseminating findings of 2020. They will be released soon, but the prevalence is much more or less the same. It has not gone. They have not gone down so much. But interestingly, we have some other groups like the fisherfolk. There is a study also which was conducted around Lake Zone among fisherfolks. The prevalence is far higher, about 14%. But also along the central and the southern transport corridors, the prevalence are much higher. So these are the population groups that we need also to be focusing on as we address the HIV response in this country. Unless we don't leave anybody behind, otherwise we may struggle to control the epidemic. The number of people living with HIV, overall, if you look on the trend, before 2004, remember we started ART programs in this country in 2004, and it took us a while before before services were accessible to many people living with HIV. And I can see the trend. The number will decline around that years, but as we move forward, the number is somehow stabilizing, indicating that care and treatment is really giving us a good result. We have reduced deaths significantly. So regarding the achievement of the 1990, and I think Mohammed spoke about this. Basically, there are two arms. Either we are using spectrum data where we provide population estimates, community estimates. But if we are using community data, those who are on treatment, and the number of those on treatment, if you're using program data, they always be doing very better well because the denominator is decreasing. We are not using for the second and third estimate or 90s, you are not using the population estimate, but those who are accessing those services. But if you go to the community level, where you're maintaining the population estimates of the people living with HIV, the number somehow are not doing very well, as we'll see in the next presentations. Next slide. So the progress about ALT, by last year we had like 1.49 million people on ALT current, and about 2/3 were women. And among these, 93% were women on treatment, but for men we had only 77%. The other area that we are not doing well is children below the age of 14. Of the estimated, only 60%. So we are missing about 40% children in the program. PMTCT, we are standing at a coverage of around 80%. And the mother child transition I mentioned earlier, around 11%. So treatment custody among women, this is the population estimate, the structural model. For women, we are doing much well. We are almost at 90%, over 90%. And it has been progressively improving over time. For men, we are still struggling, especially for all the three, the first 90, the second 90, and the third 90. For children, that's why we still have a serious gap. About 40% of them are not identified, are not diagnosed. 60% are not on treatment, and around 45% are not virus suppressed. And if you look at the trend of the number of children living with HIV, it has been decreasing. It's not stable, and this could be explained that it's quite a lot of death happening, given the fact that new infections are coming. You see transmission still high, but the number is going down. That means the only route they're escaping through is death. And we'll see in the next slide. So overall for the program data, the majority, as I said, are women close to 1 million on treatment, and many around 500 on treatment. And we have about closer to 6,000 children also on treatment. Regarding age-related death, about 28 or 29,000 people lost their lives because of age-related mortality last year, but over half of these deaths were among men, and 21% of the deaths were among children aged below 15 years. But something of very much concern is that among children aged below 15 years, over 3/4 of the deaths are among under 5. So children below the age of 5 years are the ones mostly affected by this indicator. So we need to do quite a lot to identify those children, but also to make sure that we put them in care and treatment. So this is all about the trend over time on death. Now coming back to the epidemic control, when you compare between death and new infections, remember, as I said earlier, we started ART programs in 2004, and it took us time before we were able to ensure that these services are available to everyone. And you see the projection there, the number of infections started going down, but also AIDS went down very quickly. But the speed at which new infection is decreasing is not giving us hope to control the epidemic. So if you take Tanzania as the regional comparison with the Eastern and Southern Africa, which is a region with around 650,000 people. For reducing new infections, as of 2020, we are at around 38%, and the target was to reduce by 75%. So we are really struggling to reduce the new infection. But for AIDS-related death, we are doing well. We had made a target to reduce by 50% in 2020, and we are almost there. Now, what are the key challenges in the HIV response? If you look across the two surveys, especially the 2003-2004 and 2016-2017, regarding young people, comprehensive knowledge has gone down. And even if you put all these three of the four surveys together, the picture is the same. So we are no longer, perhaps we are no longer targeting this group very critically in terms of giving them the knowledge. Remember, these are young people, they are graduating from one stage to the other, so they need to be getting this information continuous as they move or as they graduate from one stage to the other. And these are people in schools or out of schools. So we really need to have programs that are addressing the HIV among these population groups. And given the fact that you still have a lot of new infections happening among these young people. We have already said this, high infection among young people, and to be specific, by last year we estimated that around 11,000 new infections happened among adolescent girls and young women. And for boys, we had around 4,000. So it's about twice, more than twice, to be precise. But condom use is also still very low. And if you look at all these four surveys, across all surveys, it has also remained below 40% among people who engage in high risk. And for key populations from the 2017 report, for MSM you have around 14%, female sex workers was around 7%. Domestic funding is also an issue. If you look at the report, the previous report, the most recent report, the National AIDS Spending Report, the government contribution is around 10%. But of course, this excludes other contributions like infrastructure, but also human resource, including salaries and development. Mother-to-child, we have said, for MTCT, for mother-to-child transmission, the other problem that we are struggling with is the testing, identifying these HIV exposed babies. We are around 68% for the first test. And we know there are subsequent tests. They have to test maybe at 6 months, 9 months, 18 months. But for the first test, we have only 68%. So if you are unable to identify HIV, infected kids at this age, it means they are more likely to die of AIDS-related death because you are not putting them on treatment. So it's an area that we need to improve the way we are doing our interventions. Stigma also still high, still at around 26%. But overall, we are seeing there are some population groups that are left behind in terms of achieving the 95 targets. And these are fisher folks, people along the transport corridor. If you look at the TCN study, the study that was done on the central transport corridor. But also children, we had 60, 60, 55, and the men. Thank you very much.
Asante sana Dr. Sumba for a very elaborate presentation about the status of HIV in Tanzania. I would like to welcome two burning questions before we go for a break. Questions or comments? Yes, Karibu.
Hello, good morning. Thank you for the nice presentation, Dr. Sumba. I was a bit curious about the targets. According to the message from the AIDS 2022 by Professor Ngure, it indicated that no region in Africa has reached the 95. However, in Tanzania, it indicates that the two last indicators have reached to 97%. How did Tanzania manage to reach those targets to 99% and 97%? Thank you.
Thank you. As I said earlier, it depends. Are you using the population level estimates, or you're using the program that progress performance? Because there are two things here. The first arm maintains the estimated number of people living with HIV as the denominator. So if you're using the population level estimates, the number will be far lower. But if you are using the program data where the denominator changes, decreases as you move from the first 90 to the last 90, those numbers will appear pretty well. This is what happens. So you have to be very careful how you're interpreting those 90s and 90s. Yeah. Otherwise it will be confusing, but it's quite clear.
Karibu, please identify yourself before you speak.
Good morning, everyone. My name's Kotni Otieno. I'm here from Kenya, and I represent Men for Positive Living. So I've been listening to the reports and the presentations, and I'm just very worried concerning our young people, because these are the people that we are looking at that will be our future leaders. And I was looking at you were talking about domestic funding, which is a less issue within Tanzania. So I just wanted to know, what is your engagement with this government? Are you able to tell them the needs of these young people? And if you are able to tell them the needs of these young people, is it escalating to the young people in the community? And then at the same time, what is your engagement with these young people? Are you able to engage them in a forums where they're able to, where it's a free environment, that each and every person is able to express himself or herself and be able to identify some of the barriers that normally brings this new infection within our society? And also, I was looking at the mortality among mother-to-child infections. What is your best practice to address these kind of issues? Are you able to engage these mothers and be able to put them in a situation where they are able to know that the child that they are bringing into the society is very important to us? So if a mother have given birth, for her to prevent these infections, is she in a position to know that there is a medicine that is supposed, even if you give birth to the child when she's at home or when she's not able to access the public health facilities? Is this woman in a position to have the medication to be able to give the child to prevent the new infections? Yeah, though I have a lot, but we will continue to engage as we continue. Thank you.
Thank you for the questions. As I said earlier in the beginning, that some of the program-specific issues I think would be dealt with by my colleagues from specific programs. So I would ask you, Dr. Wena, if, or Jerry, or any other person working on the PMTCT program, if you could shed some light on that. But regarding engagement of young people, well, I may not be in a position alone to speak how much we have engaged, but at least I know there are programs going on to address the issue of vulnerability among young people. But the most important challenge in this case is perhaps the coverage of those programs are not that much very rewarding, because we have programs like AGY and the DREAM programs, but these are being implemented in some few selected regions, but the plan is always to scale up those programs. We understand it, I mean, as HIV programmers, that we have a very serious issue to do with young people, and there is no way we will be able to control the epidemic if we are not able to cut transmission of new infection among young people, but also make sure that we put those on treatment, I mean those infected on treatment, and continue monitoring. Unless there is any other person in the audience who maybe has some contribution on those areas, please, you're welcome.
Thank you very much. I would like to shed light on something on PMTCT, as you asked. You wanted to know whether those who are delivering at home can have access to preventive services. I can say yes, because we have different models on delivering ART, and we have ART delivery model at a community level. So what happens is at community levels we have healthcare providers who are called community healthcare, community providers. So if they identify such a person, they link to the corresponding S facility and have the medication to that person who needs it through the S facility, then the community ART. So we never miss those people in there, and we have a very good community service. So I think that can be taken care of through that model. Thanks.
So let's have those three as the last. Hapa kuna dada pale simuoni vizuri, Dr. Isaac, and then there's another hand there. Tutaona muda unaendaje.
Thank you. My name is Dr. Isaac Maro. I'm here from representing Clouds and IFACARETS Institute, so I'm wearing two hats. One thing I've noticed is we are seeing, it's sad really, that the young population is really left behind, and men too. And coming from the media perspective, I think this is not surprising really, because there are really no funding when it comes to really engaging young population. So to be honest with you, young population is not really included. So right now in the media, we hear less and less of advocates for HIV, education for HIV. We do not hear anything. And that is media, the bigger picture. So I assume in the community as well, the picture is the same. We have really left them behind. And I feel like if we do not do anything about it right now, then that 60 that we are seeing right there, 2 years to come will be 50, it will be 40. And the young population now is the bigger part of the population. So I'm really saddened to see this, because I know for sure that we are heading in a really wrong direction. So I don't know what we can do in the programs part, but I know that we write a lot, we hear a lot in the writings, that we're engaging young population, we're engaging girls and young women, But the reality now we're seeing right there is very different. I cannot talk of men because that is a whole different aspect, but I can really say that we really have to do something when it comes to this young population. Otherwise, we are heading in a really, really wrong direction. That's all. Thank you.
Thank you very much. My name is Dr. Agnes Kosia. I work with Christian Social Services Commission. I want to contribute to what is a government practice in relation to PMTCT. At the moment, the government of Tanzania, we have a project called Mother Mentors, and is funded by a global fund which is implemented by a government, AMREF Tanzania, and the CCC. The role of Mother Mentors is to make sure that they make a follow-up of those mothers who are taking HIV and lost to follow up and return back to. We have seen the impact of this, and we recommend, I think the minister already recommended in the MTCT Plan 3 to be integrated in the whole countries so that we can track mothers and baby care in relation to care and treatment. And second thing, we have seen that we have a MTCT which is almost 11%. The government, the issue, as the doctors say, we have an issue of a secondary test. The government has a PMCT unit collaboration with CRS. They have integrated maternal testing. So we are now advocating for maternal testing at EN, so that we have seen the through advocacy, mentorship, so that we can, because healthcare workers, so that we can able to have a maternal testing 32 weeks, 32 weeks. 38 in postnatal, as well as a way of addressing issue maternal, high maternal counseling, high maternal transmission in the country. So that's what I wanted to contribute. Thank you.
Okay, thank you. I'm Claudio Senges. I wanted to contribute from very nice presentation. My idea is, or my question is, what the country commitment out of donor support to all these gaps? Because we could have a policy, but if the policy is not supported by ourselves as a community, as a government, as contributors, it means like we are doing something because we know we want to mobilize the resources outside. So if we say young people, little miss interventions, what is something like a TOZO or something like a government domestic commitment? Yeah, government domestic resources that will be able to push something to see that, so that we can say, oh, we are doing this by ourselves. So others who come, it's more like supporting us and not like making us feel like this is what we are doing. That's number one. Number two, from presentation, stigma looks like it's a better challenge. Let us go and think, how do we engage everyone to address stigma? Do we engage because we are professional? Do we engage as a community? How do we engage? So if we find all those ways, we will reach a point that we can minimize levels of stigma by ourselves, not by just looking outside who is coming to support us. Thank you.
Thank you, Mr. Claudio. I think there's a question and a comment. So before you respond, I would request the gentleman Harper make his point, and then you can respond to Mr. Claudio's comments.
Okay, thank you. My name is Abdullahi Chereta. I work with Positive Society Tanzania, and I want to pose my question to your current key challenges. I've seen the low condom use at high risk population. To the MSM, I've seen you for 40%. And according to my experience, I've been hearing about this issue, these challenges, for so many years. And you as a government, you are aware that most of MSM do not use condom because of there is no water-based lubricants in a country. Most of them do not access water-based lubricants. And the government banned, on 2016, the government banned water-based lubricants. My question is, don't you see that it's high time now to allow the usage of water-based lubricant in a country? Thank you.
Asante. Mostly were comments, but I will try to speak a few words on the questions. Number one, I agree with Dr. Malo that perhaps we haven't engaged very well the media to support some of the programs addressing the issue of young people. But the bottom line, I think, is about funding. You remember when this funding landscape changed, the amount that is allocated for HIV sensitization programs, including use of mass media, also went down or non-existing at all. No wonder you don't even get those messages you used to see on TV or radios. And the argument has been about the effectiveness of those programs. They are very expensive, but then how do you associate the result with those programs? Because it's not easy to measure that this amount of money injected into some radio programs or TV programs has resulted in this amount of results. Unlike on care treatment, if you put this money on care treatment, you are able to see how many people are on treatment. Or if you put to testing this amount of resources, you are able to count those numbers. So in a way, some interventions are encouraging funding, and given the fact that all this funding, almost 96%, is donor supported. So the thing there, I think, is funding. But all in all, as a government, I think you are quite aware that for the last 3 or 4 years, there has been an initiative to establish the so-called AIDS Trust Fund, and it's on board, and it's trying to mobilize resources. The only challenge that we have is ATIP, that we haven't got a clear source of funding, like somebody was saying there also. So we depend on a donation and charity, which are not sustainable. So until when we identify and get support from high level of getting a specific and sustainable source of funding for ATIP, then we'll be able to finance some of the programs. Like in this case, if we had money, perhaps we could put on these programs to provide education to young people. The same thing we are facing with STI. STI is not getting funding from Global Fund or from PEFA. Opportunistic infection likewise. So those are the areas that if we had our own money, perhaps we would go and inject more, because they are not funded well, as well as the blood safety. So those are the areas that really we need to mobilize resources and fund those programs. We know they are very critical programs. Regarding the issue of condom, overall we have a critical challenge with condom use, even for the general population. That the way that we have been programming condom to reach to the community, I think, has been not really giving us good results. And currently, there are strategies that to ensure that these condoms reach to the community. So we have tried diverting the mechanism of condom distribution. Rather than putting them in these facilities, now the focus is to push them to the community. And as you are aware, the country have installed over 50,000, I think, or 100,000 condom dispensers, especially around hotspot areas. So these are some of the initiatives or the mechanisms that the country is trying to to move forward and ensure that condom becomes available. The other question from Zungu, I would rather not engage in that discussion. Thank you.